welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I'm your host, Dr. Harveer Sayan. Thank you so much, as always, for joining me here, guys, to learn and to grow. I'm always so grateful for all the support. As always, a big request right off the top, if you could, please do share it. Send a link to your friend, put a link on LinkedIn or Snapshot on Instagram or Facebook or wherever you spend your time and wherever your friends and colleagues are. Please do share this with them. Let our friends and colleagues across the country know that we're having these very important conversations. And this one in particular is a very, very important conversation. Today's episode is the second part of this two-part series that we're doing on scope expansion. If you didn't hear the first one, you don't have to listen to them in order. Once you're done with this one, please go back and listen to the other one. The first interview was with Dr. Shaina Nensi, president of the Ontario Association of Optometrists, and Dr. Sophia Leung, the president of the Alberta Association of Optometrists. This episode, the second of these two, is with Dr. Evelyn Lo and Dr. Sarah MacIver. Dr. Evelyn Lo is the president of the BC Doctors of Optometry, and Dr. MacIver is heavily involved. She's a director at the University of Waterloo School of Optometry. She's the director of the educational program. So she's overseeing student education, clinical education, and making sure that the students coming out of Waterloo are trained up to the fullest level, the highest level, to fullest scope. So when they come out of school, they are prepared to practice anywhere in North America. And so you're going to hear from her today in this episode and how University of Waterloo is preparing students to practice at the fullest scope. And of course, why is scope expansion important? Why should we be practicing at a more expanded scope or a higher level? These are the types of things we're going to talk about today. And as I said in the last one, I deliberately do push a few buttons. I want to make sure that we're thinking critically about this. Why do we need to expand scope? Should we? Who does it benefit? Who's opposing it? You know, who are our biggest critics out there? How can we make sure we're prepared to have the right conversations with them? Who do we need to speak to in government to make sure that the government and the people who are making decisions in government understand why optometry is important and why expanding scope for optometry is important? So all of these things are going to be covered in this conversation, and were covered in the first of these two conversations as well. So make sure you go back and listen to that one if you haven't heard it already. Make sure you give me your feedback. You know, reach out to me, whether you find me on Instagram or text me or LinkedIn or YouTube comment section, whatever it is. Leave your thoughts. Even if you don't disagree, you know, and I think that's so important, is let me know if you don't if you don't agree, if you do disagree. Very important to let me know if you disagree with some of the things we said, because I'd like to know what our friends and colleagues are thinking. What is the conversation that's happening out there, and how can we make sure that we're approaching this the right way? Because ultimately the goal is to grow our profession and to help not just this current generation of optometrists, but future generation of optometrists as well, to thrive and to succeed. So without further ado, here is the second part of this two-part conversation on scope expansion. This one is with Dr. Evelyn Lo and Dr. Sarah MacIver. Hope you love it. Let me know what you think. Hello, and welcome back to another episode of the 2020 podcast, Canada's #1 optometry podcast. I am your host, Dr. Harveer Sayan. Thank you so much, as always, for taking the time to join us here to learn and to grow. I'm always so grateful for all the support. As always, I have a big favor off the top. If you could, please do share this with a friend, with a colleague, with your family, whoever you think is going to get benefit from this conversation. Send them a text message, put a link on LinkedIn, put a screenshot on Instagram, because these are going to be some very, very important conversations that we're having here today. We are going to be talking about the scope expansion in the profession of optometry, specifically in Canada. And I have two amazing guests who are perfectly suited to have this conversation. Dr. Evelyn Lo, who is the president of the BC Doctors of Optometry, and Dr. Sarah MacIver, who is an associate clinical professor and the director of continuing professional development at the School of Optometry at Waterloo. And this is going to be the second part. We've already had one of these conversations with two amazing guests, and we're going to have another in-depth conversation here to talk about why scope expansion is important for our profession. We're going to talk about who is opposing it, and how we can go about getting this scope expansion to happen. So it's really, really great to have this conversation. I'm glad that we get to do this on the 2020 podcast. As you know, my mission is to help the profession to continue to grow, and these types of conversations are going to help do that. So without further ado, let's dive in. I'm going to give you guys some time, each of you some time to introduce yourselves. So why don't we go with Dr. Lo? Why don't I give you the mic first? Please tell everybody who you are and why you're here.
Thanks, Harbir, for the invitation. It's a pleasure to be back on. For those I haven't met, I am Dr. Evelyn Lo and current president of BC Doctors of Optometry, otherwise known as BCDO. I think this conversation is extremely timely, just because similar to Alberta and Ontario, BC has also submitted our scope proposal to the government earlier this year. And so we all want to work towards optimizing the scope of practice in order to improve healthcare outcomes for our patients.
Absolutely. Dr. MacIver.
Thank you so much for having me. This is my first time on the podcast.
Oh, hey,
I am
welcome.
honored to be here. I'm Dr. Sarah MacIver from the School of Optometry and Vision Science. And in my role as Director of Continuing Professional Development, I have been part of the development process for the Advanced Procedures Certification course, and also integrating some of the newer I shouldn't even say newer, and that's why I'm so excited to be here today to kind of talk about this evolution and how a lot of the things that we ask for in scope is stuff that's been part of our curriculum for a long time. But ensuring that we have ways to highlight some of these things in our curriculum, point to them when we do get those questions from provinces and states that are asking about that education piece, because I think that's a major reason that we get that pushback. So we've been quite involved with some of the support to provinces and to states to just show how our academic program does reflect what these scope of practice expansion asks are.
Got it. Great. All right. So before we dive too much into, the nitty-gritty of scope expansion and what it's going to mean for our profession and our colleagues and all of that, I think maybe we take it step by step. Let's talk about how do we define scope? And how do we define scope expansion? What are the things that are expanding as far as scope goes? I think it's just important that everybody gets the lay of the land before we get too confused about, sometimes I think when I have a conversation with someone, they're maybe pushing back on something that's actually not what is happening, if that makes any sense to you, right? So I think it's important that we define those things. And so that way, if somebody has pushback, it's a bit more relevant to what the conversation actually is. So anybody want to take the lead on that one? How do we define scope?
I can start. If I wanted to put it in a nutshell, scope really is the extent or the breadth of what we do and how we practice as an optometrist. So in BC, we're governed by an act which states what our responsibilities are and our limitations. Essentially, it's what we can or can't do. But this is often based on our level of education and training. And this applies actually to many areas of optometry. So that can be, of course, medical optometry, but it could be like myopia management, dry eyes, specialty contact lenses, vision therapy, low vision. The list really goes on. Mm-hmm. It just so happens right now we're talking and really honing in on the medical side. Versus expansion, really, as the word puts it, we're asking for an increase in what we are permitted to do. And I would say as an American trained optometrist in BC, the educational curriculum that I studied under already gave me the ability to actually do many of these requests. So it's not really new. And so from BC's perspective, what we're actually asking for in a scope proposal is for scope modernization. It's not so much scope expansion, because really we know how to do this, and we've learned it. And really just want to be able to practice to the highest level of our education and training. When we look at it from a healthcare standpoint, actually, it's extremely inefficient. And honestly, it's a waste of human resources for us not to empower those who have the correct expertise and training to actually practice to their fullest scope. Mm-hmm. And in fact, it actually detracts our healthcare professionals from practicing in places where scope is limited. So none of us really want a brain drain. We know the healthcare system is already fragile enough. We need to really be there to alleviate the pressure.
I like that, the way you phrase that, modernizing the scope, because we keep thinking, I think there's some conversations that are like, well, we're going to get into this, right? But why do we need to keep growing it or changing it or expanding it, adding new things? But really I think it was maybe Shaina who used this term, was really, in some ways, we're just catching up. In a lot of ways, especially when we talk about BC, we're just trying to catch up. We're just trying to be on the same level as like everybody else. And then of course, then there's things beyond that. But that first step is let's just catch up. Let's just get up to speed with what is not even like if we're comparing to so many states in the US, but just in Canada, what has sort of become the standard of care for an optometrist to provide. Let's just get to that first. And then we can go beyond and discuss how much further we can go. Sarah, do you have anything to add to that?
No, I agree 100%. It really is modernization. And being at a Canadian school, I mean, we are all governed by the same accreditation process. And so I'm always signing forms for our students that are going to Kentucky or they're going to Oklahoma to say, yes, we do teach all of these things as part of our curriculum and part of the skills assessment. So really a lot of the conversations with other academic institutions in the States as well is just trying to emphasize that point of the lateral translation of a lot of these things being, we think injections as being completely outside of our scope, for example, but we've been doing things like dilation and irrigation, foreign body removal. Those fine motor skills are what we're developing to be able to do these further things that maybe seem so far beyond what optometry is. It's not. And we've been doing injections as part of our curriculum since 2011. So it's not new to optometry, right? It's just that that modernization of optometry and also trying to keep up with the complexities of the healthcare system right now. I mean, Canada is not in a great spot with the healthcare system and access to care. And right now it's so reactive in terms of how we approach care for our patients. But really what optometry is great at being is proactive. Let's get on top of it so we're not catching up and our patients aren't losing more vision by giving them more access to care. So yeah, modernization for sure, not expansion or anything beyond what we're already doing.
Right. I think that's so key. And I like that point as well. I think, I think we pride ourselves on being sort of more preventative care type practitioners as well, right? We're not always, we'd prefer to be able to help prevent vision and ocular health issues in the future if we can, versus having to treat all the time. And I think optometry, it's nice. That's one of the nice things about our profession is that we are always on top of it. And we're trying to prevent things from happening for our patients versus treating them after they've happened. So that's great. And that's something we're going to get into is the level of training that students do get at Waterloo. It's interesting that you actually have to sign forms. So they're allowed to go practice in these states that have this really broad scope of practice. I was wondering, we're going to talk about the history of scope expansion here in just a second. But I was going to ask you, what have you seen or heard that students or doctors are doing in Oklahoma and Kentucky? But maybe we'll save that for later. Actually, there's another question with that might be more relevant. So let's rewind the clock first before we jump too much into the future. Let's talk about the history of scope expansion, Evelyn, because I think it's really important. We need to know where we've been before we're talking about where we're going to go. So what's happened in BC over the years and how have we gotten to where we are today? So I'm going to let you take the mic on that one.
Yep. So in BC, 1994 actually was the year we had the ability to use the title doctor. It's the same year that we actually got diagnostic drugs, so DPAs. It took 15 years afterwards, so 2009, in order to get our prescribing rights for therapeutic drugs, and that was topical only. Then 2012, we had the ability to initiate glaucoma, which meant that we could only prescribe one glaucoma medication. And anything beyond one, we couldn't do a combo drop, you would have to send it off. So we had a lot of limitations in our first, I would say, roughly 20 years. And it wasn't until last year where we actually had the ability to fully treat glaucoma and manage glaucoma in our offices without those restrictions. But to this day, BC does not have the ability to prescribe oral medications, including antibiotics and antivirals. And that is first and foremost one of the things we must get.
It's kind of crazy to think about. So it's been 30 years since we were allowed to use the title doctor and we got the diagnostic drops. So, your tropicamide and your whatnot, right? I assume that's what we're talking about, alkane, tropicamide, that type of stuff. 30 years. That first of all doesn't seem that long ago. But then when you look at it in 30 years, not that much has changed. We got TPAs 15 years later, and then finally another like 15 years after that, glaucoma. not a ton of evolution given how much we've seen in other provinces and other states. So again, going back to the phrase of modernization and actually just trying to catch up. It's pretty incredible, where we're at right now in BC, especially. So can you talk about the importance of orals? I've talked to colleagues from across the country even. So we're not even, let's say we're not talking to people in Oklahoma, right? I'm talking to friends across the country, or we go to a conference maybe in the States, and we'll talk about prescribing doxy or something like that. Oh no, sorry, I can't do that. I got to send them off to somebody else. And they just stop. They're like, no, I'm sorry, I said doxy, not like some. No. Yeah, we can't prescribe that. I'm sorry. Like they're like, no, not like any narcotics. No, just that. We're not able to prescribe that. And when you have conversations with other provinces, what do you see in that regard as far as how long have other provinces or other people in other places been able to prescribe orals?
I mean, definitely our neighbors have been able to do it for a long period of time.
Yeah.
I think what it comes down to is looking at access to care, right? So if other healthcare providers are able to do so and we are trained to do it, why shouldn't we be able to do it?
Right. Let's talk a little bit about what I was kind of alluding to earlier. How has scope expansion been beneficial in places that have expanded their scope? So that could be in other provinces, if we have some references to other provinces, or Sarah, as you were referring to, down in the States, places like Oklahoma and Kentucky, what have you seen? Of course, your students are training to that fullest scope. So it'd be interesting to hear how it's been beneficial.
Well, I think we can see it in our own office too. Whenever we do get that expanded scope or that modernization, even that expansion of the glaucoma medications that you had in there, it allows us to be able to manage our patients to best practice principles. Giving limitations in scope just means that if we're going to say we can treat glaucoma but only treat it with X, we're right now setting us up for failure in some way, because we're not able to be able to best manage these patients. And even having those conversations with them then to say, I'm sorry, I can diagnose your glaucoma. I could give you this drug, but I can't give you this drug, so I'm going to have to send you somewhere else. Then diminishes their trust in the practitioner to some extent, to say like, oh, is this a really dangerous drug that you want me to go on then, because it's not within your scope. So it does really impede access or even trust in the profession from the public standpoint as well. We actually have a number of our graduates who go and do a residency in Oklahoma. Interestingly enough, it's almost like a Canadian residency program, because it's one of the only programs in the US now that can accept Canadians, because there's been some visa restrictions. And so we have a lot of them that will then come back and participate in some of the training programs too. But I think because they've been doing it for so long, it's an adjustment to then come backwards and not be able to give them the stuff that just has become so routine to them in their practice. Oh, here's a chalazion, I could remove it for you, or we could wait weeks, months, and see if it resolves on its own, and then wait another couple of months to see if we can find a practitioner that's going to go and remove it. It's so frustrating for them, and to see them come back to it. And certainly it's frustrating for us when we see those patients in our chair too, because they don't want to, you say you have to send them to the ophthalmologist and they hear surgeon, and then it becomes this big thing of, I don't want to get surgery on my eye. It's just a little chalazion. But if it's, it is a safe procedure, if they just do it here and they see the comfort and that kind of progression of management, it's just so much easier and beneficial to give our patients the best access to best practice and be able to treat them the best way and what we know, because there's an evolution of best practice guidelines. There's always going to be, and if we can't keep up with that, then like I said, we're setting ourselves up for failure in some extent, or whoever's restricting our scope is setting us up for failure.
Yeah, that's not up to us, I guess, but they are definitely setting us up for failure. It's a very good example of that, right? So I see you have glaucoma, but I can't really treat it, so it doesn't exactly make the practitioner look amazing, and you said, it doesn't build confidence. You'd mentioned that there was some studies that were done that kind of showed some benefits of scope expansion. I wonder if you could touch on that.
Yeah, so there was a paper that came out, I think it was last year, and it went through and it looked at whether or not there's been a positive impact on the expanded scope of optometry. It wasn't looking at so much the minor surgical side of things, but even just being able to prescribe to the full extent, being able to help with the management of diseases, looking at better access to blood tests and all of that other stuff that we're all trying to catch up on. And it did show that there was an improvement in patient outcomes, improvement in saving vision, and all of those things that we always say, this is why we're doing it, but there's no proof of it. There actually now is that supporting evidence to show that it has made an impact in being able to help our patients to the extent that we believe that it definitely would. And so, yeah, it was compelling and nice to see it too.
Right. Absolutely. Nice to see it. It's nice to see the proof actually documented the benefit of expanding scope, because that'll help sort of kind of quiet some of the concerns that even people within our own profession have, right? What is the reason of why do we need to expand scope, which we're going to get into as far as people who are pushing back on this, but that would help to kind of refute some of their concerns. And that, again, going back to just the modernizing, we're not even talking about, like you said, minor surgical or lasers or anything. That's just the steps to modernizing our profession and the scope that has been shown to have a positive effect. So that's nice to know that we're heading in the right direction. Although I think we knew that already, right? That wasn't exactly a shot in the dark. So let's talk about, this is the part where it gets a little heated, and I'm going to try to keep my cool here, but we'll get to this part about who is opposing the scope expansion, who or what, and what is opposing scope expansion. I think in some cases the answers are a bit obvious. We might expect certain entities to be opposing it, but in other cases I think it's a little surprising that there's certain people or entities that are opposing the scope expansion for optometry. So let's talk about that a little bit more. We might hear some babies yelling in the background because they're getting ready for school, so I'll mute my mic while you guys are talking. But who wants to take that on first? Where is the opposition coming from?
Yeah, I mean, I think you said it right. Like, I don't think it's a surprise to most people, but it's of course coming from our colleagues in the medical association and potentially the ones that we work with quite frequently in kind of the patient management spectrum. But it's historically been the way that we've seen it with scope expansion, where we get a lot of pushback from the medical association, and really I think it comes from a place of, well, what they're saying to patient safety. They aren't as well informed maybe about the education, the training, what optometry is already doing, but we see it in the States as well. That's been the main pushback, the main restriction to having optometry expand their scope is the pushback on patient safety education from our ophthalmology colleagues in particular. But it's interesting because I've talked to a number of optometrists who are actually very surprised that ophthalmology has such a strong stance against optometry scope. Especially because when we're working one-on-one, we get those referrals back to us where they say we're not managing glaucoma, we're not seeing this right now. So in their minds, they're thinking that this would be a welcome change in the way that we refer our patients. But I think it's something that we're always going to have to push up against. But I think we've seen changes in other profession scope, like pharmacy, like you mentioned, naturopath, where that argument of needing to have a medical degree to modernize practice is getting weaker and weaker.
And Sarah, I'll add to that. I don't think we need to hide on this one, right? So the opposition in many ways really is ophthalmology, and we really should just recognize that right off the bat. The concern that they have often is that we may not be well trained or competent to further scope. But I will quote, one of the papers that Dr. Sophia Leung was part of Basically, they looked at the outcomes of over 146,000 laser procedures that were performed by optometrists in the States. And it shows only 2 complaints or possibly negative outcomes. And that equated to 0.001%, which really tells you that optometrists are capable of effectively performing these procedures. So we really should be shifting our focus away from competency to actually focusing on the patient access to care, because we can demonstrate the educational piece.
I would, definitely have to agree with that. And I'm surprised that ODs would be surprised, double surprised, that OMDs are the ones that, or just, the medical community in general is the entity that's pushing back, or is the primary, source of opposition here, because obviously we are going to be encroaching on their territory with this, right? So it's kind of a double-edged sword for me. I feel like sometimes the pushback is pretty aggressive, like not just here in Canada, but I've seen in the US, for example, in different states where there's a bit of a battle going on, and sometimes the pushback and the comments made by the medical community can be pretty aggressive and sort of inappropriate almost at points, the way that they go out and try to attack optometry. I don't think we've seen that in Canada, thankfully, but there is still a lot of pushback and a lot of documents and websites made and stuff like that to talk about why optometrists shouldn't be expanding their scope. So it does get a little heated there for sure. But what I find funny about that, as you just said, Evelyn, about competency, and I'm not doing this to trigger anybody or to talk down to any of our ophthalmology colleagues, because of course they are extremely highly trained and they're specialists at what they do, and I don't think we should be saying that they shouldn't be doing what they do. It's just we're trying to actually support and take things off their plate so they can do the things that they're actually trained to do that we can't possibly do, right? Many other surgical procedures and other things that they should be spending their time doing and focusing on, and we can take things off of their plate to help lighten the load and streamline that referral process and reduce that wait time. But I find it funny when somebody says, an optometrist has never used a laser before. Well, I'm wondering if the ophthalmologist was born, or if they had to touch a laser for the first time at some point in their career during their training. They probably had to do it for the first time at some point, right? And then get trained beyond that. So I don't see why that is actually an argument, to be honest with you. If I haven't done a laser before in my life, but I am really motivated to get trained at it, well, I'm going to have to touch it for the first time. Or the first time I did a refraction, well, I'd never done a refraction before. I don't think I'm competent enough to do a refraction because I've never touched a phoropter before. That argument, which I've heard now from a few different people, doesn't sit well with me. Because everybody has to do that test for the first time or do that procedure for the first time, and usually under some sort of supervision, obviously. But we're going to get a bit more into that as well. But, one of the things that I found really strange, and I've spoken to a few different people as we've been preparing for this conversation. And, Evelyn, I know you've seen this as well, but some of the opposition is coming from places that we might not expect it. And for me, the place I wouldn't expect it is from within, meaning from other optometrists. And I wondered if you could touch on that a little bit as far as why do you think ODs might be opposed to scope expansion?
Javier, I knew you would ask me this question.
I'm glad that you knew that. I'm glad that means you were prepared for it.
I've definitely seen it amongst our colleagues, and I think it's actually the fact that there's an uncertainty. Anytime there's change, we are always feeling like, I don't know if I need to change. So I want to just say right off the bat, just because we're asking for this level of scope that we have the ability, many of us have the ability and have been trained in the past to do, it doesn't necessarily mean you have to practice to that level. So it certainly means you need to practice to your level of comfort and expertise, and that's where your professional judgment comes in. But you might not practice to that level of medical scope, but it doesn't mean you can't support the ask. When we achieve scope modernization, it shifts public perception of what an optometrist is, and it actually creates more value for our profession as a whole. In the end, the patient benefits, but not only the patient, we indirectly benefit from that as well. Mm-hmm. And I think you have to see the bigger picture there.
Yeah, absolutely. Absolutely agree. Just because, I mean, I was saying that I might want to do lasers, but let's say I'd choose not to do minor surgical procedures or laser procedures, just because I don't think that, I don't care to do it. Let's just put it bluntly. I don't care to do that in my own practice. Doesn't mean I should be stopping my colleagues from getting trained to do it, especially when we talk about access to care and we're talking about rural communities where somebody has to drive 4 or 5 hours to get a minor surgical procedure. Why would I want to create a roadblock for that colleague in that setting who can actually serve their patient and their community to a greater degree? I don't think it makes sense for us as optometrists to roadblock this scope expansion. Now, I do get that from your point of view, or what you mentioned there, that little bit of unease or that fear of, why am I getting forced to go through this again, this expansion and this training? But that's actually not what's happening, right? We're just trying to grow the profession and leave it in a better place in the future. And again, if I could share my opinion on this, like I'm not usually too afraid to share my opinion on the podcast here, but it with optometry, with any profession, as I mentioned, we're going to be encroaching obviously into some of ophthalmology's territory if we get any kind of scope expansion. That's just sort of the natural progression of it, evolution of it. But if we're not always trying to expand the profession in one direction, ultimately it's not just going to stay stable. I think ultimately it's going to contract, because there's always somebody on the other side who's trying to take over a bit of our territory as well, right? We've lost refraction. Eventually we're going to lose other aspects of the profession, or our hold on that at least will be able to do it, but we won't be the only ones able to do it. So ultimately our scope is going to contract if we're not always working to expand it and to grow it. And I think that's something that some of us lose sight of, is we want to keep it status quo perhaps, but it's never going to be status quo. It's going to be changing one way or another. It's either contracting, or we're going to push to grow it on the other end, so we can continue to evolve at least. And I think that's a message that I like to share with our colleagues who are concerned about the expansion. Is it's sort of this natural evolution of the profession. And to your point again, Evelyn, if somebody chooses not to do surgical procedures or other things like that, that's okay, as long as they're practicing to the standard of care that optometry is. I think that's okay.
All right, let me add 2 things on here.
Please.
Complacency is an issue.
Yeah.
It really is an issue for all of us, because think about it. If we are all complacent, where would we even get any sort of medical advancement? Right? We just think we're good enough. I don't think so.
Right.
And in my business courses right now, as I'm taking my MBA, we're reminded of what Winston Churchill actually said. He said, "To improve is to change, and to be perfect is to change often." So when we all wore our white coats and we swore that optometric oath, we have a due diligence to our patients, that we prioritize them, right? That we continuously broaden our knowledge and skills to benefit them. So we have to strive to do our best, and we have to advocate for our patient. And scope expansion or scope modernization is part of that advocacy effort, and it has to be top of mind.
Yeah, absolutely. I love that. One last thing on that note, because before we move on, because again, I know we could have the whole conversation just on this. Again, in preparation for the conversation, I was chatting with a few others, messaging people from across the country, trying to get some ideas of what their thoughts are on scope expansion, maybe where they're seeing some pushback. And again, back to the point of even optometrists from across the country are hesitant, maybe not opposing, but hesitant when it comes to this conversation of scope expansion, because I think there's a thought out there across the medical community and even within optometry that, well, the scope gets expanded, now everybody just gets to free will just practice at the full scope. I get to just buy a laser and start doing laser procedures on my patients tomorrow. And I think that's really important that we clarify that that's not how it would go, and that there would be, an immense amount of training and certification and all of this that would have to go into place before anybody could actually start doing these procedures in their office. Could you just take a second, either of you, to just sort of, what would that look like? And just to clarify for those who are concerned about that. Maybe Sarah, you might be the right one for that.
Yeah, I think we've seen it with glaucoma to some extent, right? We were given this opportunity to really jump in to help our patients that have glaucoma, mild glaucoma, moderate glaucoma, those patients where I think we really see, especially, I've been doing this now since 2011, where I see a lot of glaucoma patients, and I can see the difference between an optometry outcome of glaucoma when we're following them closely, we're being due diligent to the little changes in their management, compared to ophthalmology when they're dealing with, or some of our ophthalmology colleagues when they're managing some mild glaucoma, where they're more concerned about the advanced glaucoma. So the mild ones kind of accelerate more quickly. I can see the benefit that optometry has in jumping in there on that spectrum of it, but I feel like our profession has missed that opportunity to jump in and be able to see the value that we can bring to treating these patients that fall within our scope of practice. And some of that has been a resistance in some way to the education and getting that additional training. So you're right, you need to invest in the skill development, if it's something that you haven't been doing and you want to be more comfortable with, because otherwise we will see that our profession won't do it. So I know that wasn't exactly your question about it, but I think as optometrists, especially in Canada, and what we notice with our students is, as a whole, we're a pretty cautious profession. We've been told for generations that we're not at the level of ophthalmology, and we're not as good, and we shouldn't be doing it, and we have to be careful, and if we make a mistake, they're the first to point it out to our patients, right? And so we kind of have this fear of it. So it's this notion. So I find it interesting when people do say, you're going to get this right, and they're just going to go crazy with it, because I think most of us are self-reflective enough in that we need to develop that skill. So I did a residency in disease, and I came back and I started managing it right away. But had I not used that skill and that training right away, then I probably wouldn't feel so comfortable in it right now. And I think that that's what we'll see with this scope, is that we need to see and give opportunities for training and education, so that those skills can be honed, so we are jumping in on it, because otherwise it's almost like a missed opportunity for what we can be doing for the public. And that complacency is probably part of that issue, and there's the remuneration, the getting the money that we deserve to do it. But it's not ever gonna be something, and it never has been, where we get this scope and all of a sudden we're all just going crazy and we have no idea what we're doing with the outcomes and all of this stuff. So I find it to be an interesting fear. I can kind of understand where it comes from, to some extent, based on what we're told. That we see it with our students when they go out on their external rotations. We have people that think they're managing a disease, but in their mind they're making the diagnosis and sending it out right away for a second opinion with ophthalmology to confirm their diagnosis. That's their idea of it. And so I think, there's a spectrum, but I think as a whole, if we're making that investment in ourselves, we'll see the value that this can bring, and that is regardless of where the scope modernizes or expands to.
Right. Evelyn, anything you want to add on that, as far as kind of what type of training, or what would you foresee as, like, if we were to get scope expansion, surgical procedures and things like that, what would someone need to go through? What type of training or certification before we're able to actually do those procedures?
I think the most important thing is understanding that it's actually a collaborative effort. So the college is, in BC at least, how the college is going to be the sole body, the entity that's actually going to tell us, well, we're developing, this is the criteria for what you need to meet in order for you to actually proceed with this procedure. And so BCDO will definitely be working with the college to help to basically get that passed through. And of course, at the end of the day, it really comes down to those at the college. But it is our job to also support the college in that. As to what that will look like, it's hard to say at this point in time. You just have to advocate first, and the rest will follow.
Got it.
And I think, just to jump in there too, we get the question of, well, why don't why doesn't ophthalmology set that standard of what that looks like? Maybe you should allow them to create these training programs and the supervision of these skills because they've been doing it for so long.
Mm-hmm.
And I get colleagues that say, you know what, why wouldn't we do that? And part of what the Ontario Medical Association wrote back to us is you should really be relying on ophthalmology to tell you what foreign bodies you're allowed to remove. And I think a big problem with that is, we're not ophthalmic technicians, right? We've trained to be an autonomous profession.
Mm-hmm.
And we really want to avoid that piece of it because we do have colleagues that are trained that can help with the supervision, that can help develop the training certifications. And that's what's been happening in the US. So we're going to come across that argument over and over again. And I think just if I can get any word out to those listening, that we just need to stay strong as a profession of the importance of doing it ourselves and relying on our colleges and relying on our associations to make sure that we are doing it as an effort of the optometrist being in control of making those decisions as we've been doing for so long. Otherwise, we will just be treated as the technician in all of this, similar to we see optometry doing lasers in the UK, but it's under an ophthalmology training program. So it's after the ophthalmologists have trained them to the level that they're comfortable with it, then the optometrist can go and do the laser when that's happening. And I think that's proof that optometry can do it, but not necessarily proof that it has to be done that way.
Yeah, I agree. Because then it always seems that we're under the purview of the ophthalmologist or ophthalmology in general, which is, yeah, like you said, we want to maintain that autonomy of for ourselves as a profession. I think that's very, very important. One of the other, staying on this pushback and the opposition topic for just one more question. One of the other, as I was kind of messaging different people, the other pieces of pushback I got was, well, what is the point of expanding scope if I'm not going to get reimbursed for it? And we know sometimes when we expand scope or when we add things to the scope, we don't always have the appropriate reimbursement for certain things right away. So how would you respond to somebody who's saying that, I'm not going to get reimbursed for it, so I'm not going to do it, or I'm not in favor of it?
I'll start. So from a business perspective, right? If you want to keep up with competition and market pressures, you have to show that you have a distinctive value to others. So increasing scope, it allows patients to have timely care, and they're going to return to you for their continued routine care. So the perceived value to the patient then is then going to translate into intangibles, including patient loyalty, word of mouth referrals, and eventually that's going to increase your revenues. Just because a reimbursement for a service doesn't isn't given by the government initially, doesn't mean it's going to stop us from charging for these services either. I'll take BC for example. During COVID, the height of the COVID actually, the axial length machine was first on the market, introduced, and it wasn't covered, it wasn't billable. So optometrists still bought the machine, they still monitor myopia progression because that's just standard of care. And patients were willing to pay out of pocket for it. When we fast forward last year, our association was actually able to negotiate with the government to actually create a code for axial length. So there's really no need to be discouraged by the dollar value. It might look meager at first, but we just have to remember that in healthcare, we're actually in it for the long run. We have to do well financially, but we actually have to do, more importantly, do good for our patients. And if we stay patient-centric, the money will follow.
Yeah, absolutely. And always, proud of the profession or association for working towards those things in BC and getting the different codes, billing codes, and so on. And axial length was a big one. I think we're the first in Canada to have that. Is that right?
That's correct.
Yeah. So amazing. Kudos to BCDO for that. Sarah, anything you want to add on that topic of if I'm not getting reimbursed, I don't want to do it?
I think too, it's, sort of to add on to that, what Evelyn was already saying is that it may end up being a case where we have to show that we can do it and the values of it before the reimbursement comes from the government when they can see the cost savings. And it would be a shame to have that be the limiting factor as to why we're not progressing our profession because of the money issue. I mean, as you said, we need to make a living at the end of the day, but you can invest in this, and then it will give you a return on investment in a different way. So I would hope that that's not going to be a limiting factor for our profession at the end of the day. But I mean, it is an argument we hear even with our current scope in Ontario. Well, I'm not getting paid for it, so why would I risk my license on the line to do things that are more risky? And I can understand that argument, but we can maybe put that energy into advocacy and figuring out a way to kind of get around it.
Yeah. Let's rechannel that energy
exactly.
in a different direction. I like that. Okay. So Sarah, this next question's more directed at you then. Since you are a clinical professor and you're involved with training at Waterloo, what is, if you could maybe, because we've all gone to different schools, Evelyn and I trained in the States at different schools, and many of our colleagues are, going to the US as well. But just to get a better idea, what is the current level of training for students at Waterloo? And for us, let's say myself, I graduated 14 years ago. I got trained to a certain level. If I wanted to change the level of training that I have, can I do that? Can I go to Waterloo and go to other programs? Excuse me, before I let you answer, one of the main mantras here, I think, as we're pushing for scope is education before legislation, right? So I think it's really key that we see that students are at Waterloo and at universities in the States being trained to these levels and have been, as you said, in some cases for over a decade. I'd love for our listeners to kind of understand what level of training they're getting.
Yeah, it's a great question, and especially because this is the main opposition, right? We don't have the education and the training to do it. So we've been working with other academic institutions across the states to better position ourselves to be able to better address it, because and I think one of the common misconceptions, because we are a school in Ontario, is that we will train to the level of scope in Ontario instead of training to the level of scope of North America. But we have to train to the level of scope of North America. So being in Ontario means we have to figure out ways to get creative so that we can be training to them. And that's the reason why in the 1990s we started sending our students to the US to be able to do their disease rotations in states that they were actually doing disease management. So we've had to get creative to figure out how to train our students under the fact that we're in Ontario and we have our own scope limitations. But that doesn't mean that our students are being trained to that level. They are being trained to the level where we could graduate them, and that's the reason I have to sign those forms in Kentucky and wherever they're going to say that we do in fact do a training in this particular area. So we've been doing, from the side of the topicals and the orals, we train in our didactic program to that extent, and we also do have it as a competency that they have to be able to show in their clinical education. But I think one of the limitations or the reason that it's been so easy for ophthalmology to kind of jump on optometry is because it's a 4-year program, and we maybe haven't been able to point in the curriculum so easily to where there's overlap with the medical curriculum. So if we relook at that streamlining of our program, it's very similar to the medical schools. We're starting our kind of surgical prerequisites in the undergrad program before they get into optometry. And then we have the same foundational courses in human anatomy, human physiology, all of those prerequisites that are part of the medical school program. And then we're building on it as we go throughout the program. So our surgical information actually comes from year one when we're building on how does the body react to disease? And how does it react to wound healing? And how does it react to inflammation? And how do we monitor drug side effects, and how do we do all of that? And that's what we really want to be pointing to in the curriculum, so we can overcome those misconceptions that we are actually doing it, and we've been doing it for a very long time. We obviously don't have students going out and doing lasers on all of their rotations or doing minor surgical procedures. That would be the only part of what this modernization is that I can say that they are not currently doing on on a patient care standpoint in terms of their hands-on, but in terms of the technical skills that go into it, they are doing that. They're working on models, we work on simulations, we work on injection arms, and then the whole safety side of it in terms of the side effects that come from it, even with lasers, the side effects that might happen from these procedures, or any of the issues, we do see those clinically. So we're managing the side effects already. We're making the diagnosis, we're managing it. We refer it out for the procedure, then they come back, and then we're managing it after we're doing the post-op care. So it's the only piece that's missing is that technical piece, and not to say that that's not a small piece, but it's a piece that could be easily added as soon as we have that scope expansion, so that our students get that on their clinical rotations. And then in terms of optometrists that want to do it, and your point about education before legislation, we also have our certification course at the University of Waterloo, where we don't look at it as a weekend course, and it's not actually a weekend course because we run it over 2 weekends, but the whole goal of that is to add on and refresh some of those anatomy courses that we already do in our curriculum, because we're not maybe thinking about it as a profession every single day. So there's some refresher courses in there. And then we have our workshops where we're doing the lasers, and we're using the Model Eyes the same way that they do in ophthalmology. We're doing injections. We have it's an interprofessional course, at least where we bring in our colleagues from the medical program so that we can actually be practicing on each other, because we have licensed physicians that are helping us develop it. So, and we have them come in and teach our students as well, as a way to kind of get around it. So those opportunities are there, and I would encourage as many people as possible to seek out some of these certification courses, because I think that helps to demystify some of that stuff. And one point that you brought up with the lasers before, about the argument of, oh, well, we've never touched a laser, is actually not true. We touch a laser every single day, because if you look at a laser, it's a slit lamp, right? It's the exact same thing. We're doing the exact same thing. You just add a little button to it. And that button is so safe. There's really, with Sophia's paper and with some of the other optometry-based papers, there's really minimal risk associated there. And I really like to use the example of SLT for glaucoma in that, because by not allowing us to be able to do lasers on our patients with glaucoma, we're already not doing the best practice for a lot of our primary treatments, because we've seen that adding laser first before drops is going to be beneficial in terms of slowing down progression of disease, having a better outcome overall. But we don't have there's no way that ophthalmology can take that on and be that paradigm shift. And so really, if we want to talk about one of the leading causes of blindness and how optometry can get in there and prevent all of this vision loss, then that's a really great example of it, in terms of something we're already doing. Add on a button, we're already managing those side effects anyway. So I think the current level of training, to kind of go back to your initial question, is a lot more ready for this modernization than I think people think it is. Then I definitely know that our ophthalmology colleagues and the medical associations, I know it's way beyond what they say it is, or what they'll try and convince the government it is.
Right.
But
Yeah.
yes.
Yeah, sometimes we don't need to dwell on that too much, but sometimes you wonder if they're actually naive to how much training we have, or if they're deliberately ignorant on it just for the sake of their argument, because they must know, many of them must know, the ones we refer to on a regular basis must know kind of the level of if not training, then practice that we do. But anyways, that again, that kind of goes back to some of the arguments that they're going to protect their territory, understandably, because again, from that double-edged sword, argument there, it's if they give an inch, they know that leaves them susceptible to giving a mile potentially if we keep coming back to take a little bit more. And so they want to be protective of every inch of their territory. But sometimes the arguments to protect every inch of the territory are not exactly the most sensical. So we have to kind of just continue to make our logical arguments to show why it's so important for us to keep expanding our scope. And from what you just said about how much training that students are getting coming out of school, I think that's something that certainly does bode well for us, or work to our advantage, just to show the government and show our colleagues and everybody else out there that we have the expertise and the training to do these more advanced procedures, which are not really a big leap from what we're already doing. So thank you for correcting me on that. We have been touching that device every single day of our career. It's just that additional feature that we would need to get trained on. So thank you for that. Any other important messages we want to share before we wrap up this conversation on scope expansion?
I'll touch just briefly on what BC is actually asking for, just so that if you give me 2 minutes on the podium, thanks, Harbier. Basically, we're looking for 4 things, right? So in our modernization proposal, we're looking for oral medications, the ability to prescribe, the ability to conduct minor procedures to remove skin lesions, such as your skin tags. Of course, as well with the minor laser procedures, including LPIs, SLTs, and YAGs. And at the same time, in order to remove those skin lesions, you're going to have the ability to administer injectables.
Yep.
So those are the 4 things that we are looking for in BC. And whether or not we all feel competent, or if we feel uncertain or we're fearful of change, I think it's important that we know we can all be creatures of habit. But if we don't change now, we're going to be stagnant. And I think there's an analogy that we all remember. It's like your meibomian glands, right? You leave it untreated and it's stagnant. And when there's stagnant meibum, you get gland recession and eventually it's atrophy. So it's no different for our profession, right? If we fail to adapt and we fail to innovate, we're going to go down the same path like BlackBerry and Blockbusters, right? Whoever knows what Blockbusters is, for the younger viewers, they probably don't.
The old people on the call, yeah.
Yeah, exactly. I just dated myself there. But yeah, it's really important actually for our colleagues to know that every single one of us has to understand the need for scope expansion, and we have to do our part to support the profession. It's not something that just those people who are on the board is going to be doing. As a member of your association, particularly in BC in this case, you have to reach out to your MLAs and you have to engage in a dialogue to actually tell them about the urgency of this issue. At BCDO, we have the resources available to equip you with these conversations. So don't be shy to set it up. This is your profession. And what we do as a whole is going to shape how optometry is for our future generations.
I love that. It's wonderful. Great message to end the call on. But that analogy, that's a great analogy, the meibomian gland analogy, the stagnation and then the recession after. That's very interesting. That kind of to the point of what I was making earlier. Ultimately, the profession will contract. And just like Blockbuster, we're going to be left with just thinking about the good old days. We don't want to be in that position of thinking about the good old days when we used to go to Blockbuster to rent movies. We want to be talking about how amazing it is right now, like Netflix. So thank you for that analogy. And Sarah, anything else you want to add before we wrap up?
I might just kind of go back to the point about your education before legislation. And if you are somebody out there that is really questioning what it is that this minor surgical procedure and lasers is, and how does this even fit within what optometry is doing, I would really encourage you to seek out some extra training and some education just to see how seamless of a transition and it will be for our profession to take on that added scope of practice. And that goes for those that are interested and eager and all of that want to know, what can I do now to help with the profession, to help move it forward? I think the more people that we have as a mass that are trained and able to speak on it and speak about how this can make a benefit to our patients, the better to move it forward. So it's going to be beneficial to everybody at this point in time, even if we don't have scope expansion on the table for tomorrow, to work together to make this happen in the near future.
Yeah, I think that's great. Yeah, the more of us that are trained to that level, the better. Ultimately, it's going to work in our favor when we're having these conversations about adding this, expanding the scope. That's excellent. Thank you, Sarah. All right. So thank you, both of you, Evelyn and Sarah, Dr. Evelyn Lo, Dr. Sarah MacIver, for being part of this very, very important conversation on scope expansion. I think this is a conversation that we probably will need to keep having in different forums to keep educating our colleagues, and then, from beyond that, educating our patients and our government officials on the importance of expanding scope and why optometry should expand its scope, to provide the services to our patients. As Evelyn was saying, that's ultimately the goal, is to serve our patients better. So thanks again to our amazing guests, and thank you to everybody who's been listening to the 2020 podcast, Canada's #1 optometry podcast. I'll see you guys on the next episode.